session. We think it's going to be a very exciting discussion. On behalf of my co-chair, John Laffey, just will welcome everybody to this session, and I'm going to let John do the first introduction.
Okay, so the first introduction, so I'm going to introduce the introducer. I'd like to welcome Dr. Art Slutsky to the podium. Art is the Vice President of Research at St. Mike's Hospital, a Professor of Medicine and Surgery at the University of Toronto, and is the outgoing chair of the Interdepartmental Division of Critical Care Medicine at the University of Toronto. And Art is going to introduce Dr. Brochard.
Thanks very much, John. Actually, I'm not the outgoing chair. I'm the ex.
Oh, you're
I'm the
the
ex-chair.
ex.
Yes, I am the ex-chair as of November 1st, and it's really, a pleasure for me to introduce Laurent Brochard. Actually, it's a bit odd. You might think, why introduce someone who's just come to Toronto to have a leadership role? And I think because he is such a wonderful catch for not just Toronto, but all of Canada and North America, that we thought it would be worthwhile taking 2 to 3 minutes just to tell you a little bit about his background, very little because of the time constraints, and introduce him formally. He's not going to come up to respond to this at all, although he's going to speak later in the session. So I've known Laurent for about 20 plus years. Met him in Paris at a meeting many years ago. Laurent's academic career started, 1985. He received his MD from the University of Paris, and in 1992 received the equivalent of a PhD in medicine. And he quickly moved up the ranks, went up to the professorial ranks, was a professor of intensive care in the early 90s, 1993, vice dean. He spent 6 years as editor-in-chief of Intensive Care Medicine, Intensive Care Medicine being the major journal of the journal of the European Society for Intensive Care Medicine, and I think had a huge impact on the field, not just in Europe at the time, but internationally through the pages of the journal, and got to know a lot of individuals and published a number of interesting articles over the years, which I'm going to show you. In 2010, he moved to Geneva to be director of the ICU at the Geneva University Hospital, was there for 3 years, and we were very lucky to be able to recruit Laurent to Toronto this year as a Keenan Chair. It's an endowed chair, Keenan Chair in Critical Care and Respiratory Medicine at St. Michael's Hospital and the University of Toronto. The Keenans have been long-term supporters of St. Michael's Hospital and made this happen, quite frankly, with that chair. As you heard, he's now the division director for the Interdepartmental Division of Critical Care Medicine at the University of Toronto. Now, Laurent has had many important papers that he's published over the years. I'm not going to talk about the papers, just show you their sort of the titles, just to give you a flavor for what he's done. These papers have not just brought clinical physiology to the bedside and to the journals, but have had a clinical impact. And a number of these papers have changed practice, whether it be in weaning, whether it be in non-invasive ventilation. Arguably, this paper here led to changes in therapy which saved thousands and thousands and thousands of lives over the past number of years. Publications on hydroxyethyl starch, different levels of PEEP. And we recruited Laurent hoping that he would continue the great work that he's done. His genius really is not just in with the clinical work, but the way that he's actually been a mentor, collaborator. He's mentored many individuals in critical care who've gone on to leadership positions. He set up a network which he leads in Europe on mechanical ventilation. And he's just a wonderful collaborator, and we thought it'd be very important to bring him to Toronto. What we want him to do when he's here is increase the impact of the work we're doing and get us better known. And he's already done that. He's only been here for about 10 or 12 days. And this is, I've just actually looked at the French newspapers. He's already put Toronto on the map. It's really been quite remarkable. Not just one newspaper, Le Figaro as well, Libération. So Laurent has done a fantastic job over the past little while. So I'd like to welcome Laurent to Toronto. Toronto is one of the most multicultural cities in the world, in fact. And as you drive into Toronto, you know the population of Toronto is about 2.5 million people. It's the capital of Ontario, and I think it's a great city, but like all great cities, it has a great logo, and we'd like you to remember this, Laurent. This is very important. Our hockey team sucks, and our mayor spokes crack. So, Laurent, welcome to Toronto. And I'm not going to take any questions.
Okay, so without further ado, it's my pleasure to introduce Dr. Shehabi. Dr. Shehabi is a professor of medicine at the University of New South Wales and the School of Public Health and Preventative Medicine at Monash University in Melbourne. And he is going to talk to us about the using procalcitonin in patients with severe sepsis. So welcome, Dr. Shehabi.
Thank you, Mr. Chairman, and thank you, everybody, for giving me the honor and the privilege to present this randomized controlled trial in this fabulous forum, in this fabulous city. This is a study that's endorsed by the Australia New Zealand Intensive Care Society. And let me just, that's good. This study was funded by the Intensive Care Foundation of Australia and New Zealand. Vendors of the procalcitonin assay provided monitors for hospitals that did not have procalcitonin assay available at the time of the study. The biomarkers, procalcitonin is one of them. We look at them to shorten the time to diagnosis, whether it's infection or coronary syndrome. We also look at biomarkers to give us an indication of the severity of the disease, whether it's a coronary syndrome or an infection or sepsis, and also would like biomarkers to be able to tell us that we're on the right track when we are treating a particular disease. That's what I want to see in a biomarker that would work for me. For that reason, intensive care and infection is, lived together for a long time. We've just heard from John Louis and the EPIC-2 study and many other studies that a lot of patients in intensive care do receive antibiotics, and the clinical diagnosis of infection and sepsis is primarily based on physiological indications of inflammation and so forth. The studies that used procalcitonin has been many. Most of them had many limitations, including being single center, and it did attract a lot of interest. Even my next door neighbor asked me about procalcitonin one morning. So with this study, we hypothesized that if we use a single cutoff, and we've chosen a very low cutoff of 0.1 nanogram per ml, then that would produce a safe reduction in antibiotic exposure days by 25%. And also, we hypothesized that the decline in procalcitonin over time correlates with mortality. So the objectives of our study is to investigate whether using a very low procalcitonin cutoff as a single cutoff would reduce antibiotic in patients who were admitted to intensive care with suspected infection when compared to a control group that's managed by best practice comprising antibiotic stewardship and published guidelines. We've had some secondary objectives, which I will be talking to through the study. The study was a single blinded arm and was multi-center in 11 RCUs in Australia. 8 of the RCUs involved have never used the procalcitonin before as a biomarker for sepsis, so it was completely new for them. Randomization occurred in a central randomization through our website, and we stratified patients at randomization to those who had sepsis or those who had severe sepsis or septic shock. The data management was all done centrally by Monash Medical Center, and all the analysis was done by an independent blinded statistician. The primary outcome was the duration of antibiotic therapy and the daily defined dose of antibiotic per patient given, and we had a bunch of secondary outcomes, including predictive values of first PCT and predictive value of PCT kinetics over time. The inclusion criteria were essentially any patient whose fresh admission to intensive care, presumed infection, had 2 SIRS criteria, and is expected to stay in intensive care for more than 24 hours, and is a fresh admission, so they have not been in intensive care before. Of course, we want them to accept to participate in the study. Exclusion criteria include those who were for surgical prophylaxis, patients who are known to need prolonged antibiotics according to published guidelines, and also those patients who are known to have higher baseline levels of procalcitonin. The study algorithm was pretty simple. At first line, at first PCT, if the procalcitonin less than 0.1, then antibiotics would be ceased. If the procalcitonin is above 0.1, then according to the clinical suspicion, if it's high, then you can give antibiotics. But once your procalcitonin level on subsequent PCT comes down to less than 0.1, then antibiotic will be ceased. We've collected procalcitonin every day, so there was a daily collection of procalcitonin on all patients, and the blinded arm or the standard arm, procalcitonin was never on the system. It was faxed directly to the central data management center, while in the intervention arm, procalcitonin was provided to patients. Look at the baseline characteristics. It's quite a busy slide, but I think the things that I just wanted to highlight is that at admission, there was at least about 10% of patients who had procalcitonin levels that was lower than the cutoff. So at least 1 in every 10 patients who admitted as presumed infection probably did not have an infection. That's their most admission source. That's their comorbidities and their interventions. Essentially not much different at baseline, except that there was a slight imbalance between at age, which was probably clinically not relevant. The primary outcome, as you see, that for the whole population, there was a trend toward a reduction in antibiotic days from 8 to 11, but did not reach the statistical significance. However, the antibiotic daily defined dose was significantly lower in the procalcitonin guarded group. This trend of reduced duration of antibiotic was also seen in all subgroup analysis and was more in the pulmonary people who had pulmonary infections. When we looked at the main clinical outcomes, there was essentially as expected. There was no difference in most of the other outcomes, including ventilation time, ICU mortality, hospital mortality, and 90-day mortality. Most of the mortality was actually as a withdrawal of therapy. We also examined the predictive value of first and serial PCT levels. This graph here shows you the two groups side by side, and you can see that in randomization you get pretty much two balanced group, no difference in PCT values overall, and no difference in PCT decline over time. The picture looks very different when you look at the patients according to the culture positive or culture negative. On every study day, those who had culture positive had a higher procalcitonin than those who had culture negative. If you look at the different site of culture, you can see that those who had a positive blood culture had a significantly higher procalcitonin level at baseline than those who had lung or intra-abdominal infection. If you have a PCT value that is less than 3 nanogram per mil, then your likelihood of having a positive blood culture is indeed very low, and with a high negative predictive value. We also looked at those who had severe sepsis against those who had septic shock, and again there was a significant difference every day from first day until the last day of collection, and there was also the patient who had a severe sepsis or septic shock had a faster reduction in their procalcitonin over time. This slide here looked at the reduction in procalcitonin according to day 90 mortality. You can see that there is both groups started at the same data point, as they went with time, from day one, there was a departure towards a faster reduction in procalcitonin level on patients who survived than those who did not. You could also see that those patients who died had a late rise in procalcitonin level for some reason, which probably that they've had a secondary infection. So if you look at the odds ratio after logistic regression, adjusting for a bunch of covariates, you have an odd ratio of about 2.95 of with a lack of reduction in PCT. We found that all patients achieved 30% reduction in PCT by day 3. However, if you have not achieved 50% reduction by day 3, you have a likelihood of death that's almost about 97%. So in conclusion, ladies and gentlemen, when we compared with the standard care, including antibiotic stewardship, procalcitonin guided antibiotic therapy using a single cutoff value of 0.1 produced a trend towards a reduction in antibiotic days, but a significant reduction in antibiotic dosages. In intensive care patients with suspected sepsis, first, procalcitonin can predict the severity of sepsis, of infection. It can predict positive against negative culture, and it also can predict those patients who are going to have positive bacteremia. Decline on procalcitonin over time is an independent predictor of 90-day all-cause mortality. And we concluded that a simple algorithm with a single cutoff value for procalcitonin is useful and reliable. I wanted to thank all my co-investigators, and thank you for listening.
We'd like to welcome Dr. Laurent Brochard to the podium to give an editorial comment on the study. Thank you.
Do I move the slides? Okay. Well.
Escape.
Yeah. Okay, thank you. And great pleasure to comment this quite interesting study about the utility of procalcitonin or PCT in ICU patients. The World Health Organization, I come from Geneva, so I'm sensitive to that, say that antimicrobial resistance is a major health problem in the world, and say that all key stakeholders, including policymakers, etc., should act and take responsibility for combating antimicrobial resistance. And some clever people say that we should even declare a war, like World Alliance Against Antibiotic Resistance, to safeguard antibiotics. In the ICU, there is no question that this is becoming a major problem, and the usual recommendations say that a constant evaluation of current practice of antibiotic consumption patterns seems to be essential to make progress in this problematic matter. And the general strategy we have to prevent antimicrobial resistance in the ICU are first to be as compliant as possible with infection control measure, and second, to try to be the most adequate as possible in the antibiotic use. And as illustrated here, we should view it as a balancing act between appropriate antimicrobial treatment and avoid unnecessary antimicrobial use. So at least for this reason, there is a very good rationale to try to do better than what we do in terms of administration of antibiotic and trying to stop antibiotic as soon as possible. So in this regard, procalcitonin has been viewed as an interesting possible biomarker. So it's a peptide, a precursor of calcitonin, which is as you know, involved in calcium homeostasis, but surprisingly is increased very rapidly when there is bacterial infection. And a number of studies have showed that it was probably possible to reduce antibiotic use. These are the more than 10 years ago, this kind of study started. This is in the emergency ward. You see patients with community-acquired pneumonia, exacerbation of COPD, and based on different algorithm using procalcitonin, at least in some group, it seems you can reduce the antibiotic dose or duration. This is a very large study which was conducted in the emergency ward. You see more than 1,300 patients, and you have community-acquired pneumonia, again exacerbation of COPD. In some group, it seems that the antibiotic was decreased in terms of duration, in other groups in terms of number of patients who received it. In the ICU, there has been also major interest in this approach, and this is one of the studies relatively recently published by Lila Boanma, a multi-center study in France. And just probably hard to read, but to indicate that there were guidelines for initiating antibiotics based on procalcitonin. And interestingly, we heard today that in your study, a number of patients had low procalcitonin from the beginning. But there was also guidelines for stopping antibiotics. And this, it's important to look at the threshold in the study presented today. The cutoff used to stop antibiotics was 0.1 nanogram per milliliter, which I suppose is the same that microgram per liter. So cutoff which clearly was lower than the cutoff used in this study and in many other studies, and which may explain some of the results. So in this nice ICU study, procalcitonin was able to reduce the antibiotic therapy duration, dose, as shown on the right part of the slide, but had absolutely no impact on ICU length of stay, ICU mortality, or hospital mortality. And if you look at the different subgroups, it seems to work in the same way in the different subgroups. Interestingly, we have recently two systematic review and Cochrane review, which look at 14 trials. This is not only ICU, but this is the use of PCT in acute respiratory infection. And in fact, one of the major questions, if there is a signal to decrease antibiotic duration, is it really safe? And you see that treatment failure occurred similarly in the two groups, but there was no association with increased mortality in any clinical setting. And the total antibiotic exposure was overall reduced by 8 to 4 days, which is of course interesting. In the ICU, the results are a little bit less impressive. There is 18 randomized control trials. It reduced antibiotic duration by 2 days. This is a median value, and the same in patients with respiratory tract infections. So even with quite a large number of patients, we see the effect is relatively limited, although it seems to be quite significant. So one of the problems of this study is that the algorithm is usually quite complicated, and it was, I think, a very nice approach to have something as simple as possible. The main cutoff used, as I mentioned before, was 0.1, which is a very, very low, so we could say a very conservative cutoff in terms of when to stop antibiotic. And this may explain that the results are, on the one hand, interesting, showing the feasibility of the approach, showing a reduction in the total quantity of antibiotic given. But in terms of major endpoint, which shows the time to antibiotic cessation, the result is not significant. There is this trend, for sure, but if you look at the whole population or if you look at the different subgroups, it's hard to see a very, very strong signal. So there is something, there were less antibiotic given, but the time to antibiotic cessation was not really very impressively reduced. There are clearly strengths to this study. The protocol was simple, easy to use, and would be easy to reproduce. It was a multi-center study. The same assay was used in all centers, and the protocol violations were monitored in all patients. What are the limitations, and why is this study maybe a bit disappointing? Apart from the power of the study, which may be insufficient, there is this issue with the cutoff and the threshold. This is taken, for instance, from the website of the company which provide the assay, and you see that in the zone between 0.1 and 0.5, there is clearly uncertainty, and probably to be on the safe side, the investigator decided to use the lowest cutoff as possible, but this may result in less efficient less efficacy in terms of the reduction of antibiotic duration. Is it absolutely sure that clinicians use PCT alone? To start antibiotic, patients had to get some criteria of the SIRS, the Systemic Inflammatory Response Syndrome. So it's probably difficult to be sure that the clinicians were only relying on PCT in this study, and this is something you can probably look at in the post-hoc analysis. The selection of patients may be also an issue. There were 400 or around 400 patients randomized, but more than 1,100 patients were excluded, and all this exclusion makes sense, but these are patients we see in the ICU, which means that the impact, which is already not that big, would be reserved to only a small subgroup of patients. And regarding the type of patients, a very recent paper suggested that in some kind of patients, here it's patients with perioperative abdominal infection with septic shock, PCT may not be very efficient, a relatively large study by the group of Samir Jaber, and you see on the left patients who were who had a PCT decrease between 0.5, so the threshold here was much higher, and most of them had a success, but in the other group where PCT remained higher than 0.5, still 50% had success, so there was clearly a discrepancy between PCT and clinical judgment of success. This is again from the same study. So what other approaches could we use to take more benefit of this, or treating to stop antibiotic earlier? I think one important aspect in general is to look at the recommendation for treatment duration, which may be discussed and which could help also to reduce antibiotic duration. The study by the group in France, Jean Chastre and Jean-Yves Fagon, was very impressive, comparing 8-day to 15-day of antibiotic therapy in ventilator-associated pneumonia. And in this study, there was absolutely no significant adverse effect of reducing antibiotic therapy. So we could combine better recommendation with individual decision. And the next step may be to use not PCT alone, but maybe incorporated into a score. And again, this quite recent trial suggested that if you combine PCT, CRP, and temperature, you have the highest predictive value for the diagnosis of infection and maybe for stopping antibiotic. It's hard to see, but the yellow curve is the score incorporating the two biomarkers plus temperature. So is this the way to go or not? We do have some signals about PCT, but the signal is not so strong, is limited to selected patients, and there may be some reason in this study why the difference was not so significant. Anyway, I think it's certainly a nice way to go in the future, and we really need to congratulate Dr. Shehabi and his group for this really very nice trial. Thank you very much.
Thank you, Dr. Brochard. We're going to have a response to the editorial comment now. Dr. Shehabi.
Thank you, Laurent. I think the choice. The choice of the low cutoff was really because of many of the hospitals that participated did not use PCT before, and we wanted to give them a PCT cutoff that is, as low as possible, that will make them safe and confident that when they stop the antibiotics, they're not going to have an issue. I think one of the things that we've discussed was a mortality signal that was seen in previous studies, and also a mortality signal, an adverse event signal that was seen in the BAS study when they used an escalation algorithm rather than a de-escalation algorithm. So they were primarily the reason why we used the low cutoff for this study. I think one of the things that really struck me throughout the study, especially on our site where we've been using procalcitonin for more than 10 years, is that the confidence of the clinicians was much more enhanced when they want to make a decision, and then they will say, well, what is the PCT? Then the PCT is below the cutoff they're expecting. Then they get a lot more confident in the clinical decision making as they're doing it as an add-on. The other thing which I think probably also the study has shown us is that septic patients at baseline are different. And I think the level of inflammation is probably reflected by the height of their procalcitonin at baseline. And that may be useful for future sepsis studies to stratify patients to, different therapies or different durations of therapies and so forth. And I think it really gave us a very good insight into the level of inflammation and that not every septic patient, not all septic patients are the same.
Thank you very much, Dr. Shehabi. We have time maybe for just one or two questions. I understand we're over time.
Hi. Thank you very much. That was a very interesting study. However, there's something I'm not getting. I cannot reconcile the fact that here you have a biomarker, a certain level of which, albeit a very low level, 0.1, is used to suggest infection. The decision to stop antibiotics is based on the dropping of the amount of that biomarker, and yet, if I understand it correctly, at the beginning, at the inception of the study period, both the ultimate survivors and the ultimate non-survivors had exactly the same overall average level. And so, especially based on what you just said about the being able to differentiate the septic patient, not all septic patients are the same, and being able to differentiate the amount of inflammation, I'm having difficulty reconciling the fact that the survivors and non-survivors had the same levels of procalcitonin from the beginning.
I think if you look at the beginning, all patients had kind of admitted with sepsis and all severe sepsis, and although there was a difference in those who had positive culture or negative culture, their starting point seemed to be the same, whether they survived or not survived. I think the decline in the procalcitonin over time, we found that it's the one that really determined the departure from being in their trajectory, which occurred within 24 hours. So within the first 24 hours, you could see that there was quite a separation between the two lines. I can see your point that there's why they're not different at baseline, but that's maybe just the fact that they all bunched together as a large group, or that the number of those who died is only 18% of the population.
Could I ask a methodologic question for both the author and the respondent? And that's, in a study like this where you're looking at a cutoff and then decreasing antibiotics, shouldn't, as part of the study, have an outcome that relates to excellent outcomes? For example, if I said, well, we're going to drop antibiotics when the serum sodium drops below 100 and whatever, I'm sure we'll decrease antibiotic use, but the question is, does it have an impact on clinical outcomes? And I noticed in your study the mortality was about 3% higher in the active group, which used the Procalcitonin. I know it wasn't anywhere near significant, but without having some measure of clinical outcome, is it possible to really interpret these kinds of studies?
Yeah, I think, I mean, this is the same signal that was seen in previous trials, and I think unless the trial is planned a priori with a primary outcome of mortality, it becomes hard to look at a 3% difference and make sense of it. I think there's many contributors to that, and that's why we probably don't make much sense of it. Right. I mean, I don't know what, you know, in a trial that is kind of a pragmatic trial of just focusing on antibiotic duration and antibiotic exposure, we looked at things like readmission to intensive care due to a reinfection. That was more in the standard care arm. We looked at the emergence of resistant organisms, for example, in both groups. There was hardly any difference between the two groups, but that's because the number of isolates were small. That's why there was no difference. But I think with the mortality signal, it's really hard without looking at it as an outcome from the beginning to explain why the mortality is 3% this way or 3% that way.
It just makes it hard. I mean, I could invent a strategy where I say, you know, in the control group, don't give any antibiotics. And I'm sure that, therefore, in that group, the antibiotic use is likely going to be less, right? But unless we, as part of the primary outcome, include a clinical outcome, just hard to interpret.
Yeah.
Yeah, I think you're right. This is the reason why most of the studies, the large studies, were designed as non-inferiority trials. So trying to show that we can reduce antibiotic, but with no side effect, with being safe in terms of mortality. But in the ICU, this was, other studies were conducted on, I would say, sicker group of patients. You have a relatively low mortality. So probably from this standpoint, the study is not powered enough to show really this kind of non-inferiority. So.
Yeah.
Brian Kavanagh, Toronto. Was the antibiotic use protocolized?
It was in both groups. It was done as per the antibiotic stewardship and published guidelines. So it was not protocolized. It was done in the same way in both groups. But one group was given the Procalcitonin to guard that. One group was just done on clinical grounds.
Maybe just last question there in the back.
Hi. I wonder, and I may be misinterpreting, it seems like Procalcitonin was drawn on all the patients, but was blinded to the providers. I think somebody just mentioned it fell below the cutoff, so we're going to stop antibiotics or not. And I wonder if this became adopted in a hospital and you had the values available, might you also find benefit in those patients where it did not decrease? You're worried about their mortality risk, and you might broaden coverage or go for better source control in some fashion. Can you talk about how it might help change management in that sense in terms of escalation, not just de-escalation?
Yeah, I think I can talk from our, rather than from the study perspective, from our clinical experience in doing so. I think if a patient comes in with sepsis, we always get their Procalcitonin measured at baseline. If within 48 hours, if that procalcitonin is not really on a significant reduction, which is at least 50%, we would either look for a source that's inadequately controlled, and often we do find that, or we would optimize the antibiotic therapy in terms of either changing the class of antibiotics or changing the dosage of antibiotics. Interestingly, data that I didn't show today for the time constraints is that there was a significant difference in the class of antibiotics used in between both groups, despite the fact that the microorganisms were almost the same. In both groups, there was a significant difference in the class of antibiotics that are used between the two groups. And that may explain the way physicians and clinicians decided to deal with it based on procalcitonin levels.
Great. So on behalf of my co-chair, I just want to thank Dr. Shehabi and Dr. Brochard for a very stimulating plenary session, and thanks everyone for sticking around.
Thank you.
Big lights.